Okay, Assalamu alaikum wa rahmatullahi wa barakatuh. Jazakumullah bil khair. Thank you very much for having me to speak about very important topic, which is management of hyperlipidemia in pediatrics. So I will start with this clinical encounter, which is 4-year-old boy seen in our lipid clinic with this finding. He's the first child for his family, and the parents are very concerned about this skin finding. And this is his lipid profile, which show clearly LDL of 18 millimole per deciliter, which is really, so we have the skin manifestation and have very high lipid profile, which really indicate the underlying primary disease for this condition. So whenever we encounter a child or a pediatric patient with abnormal lipid profile, we have really to identify, is this primary dyslipidemia or this is secondary dyslipidemia? Secondary dyslipidemia does exist in pediatric. And I will tell you a story of a 12-year-old girl. She was referred to us in lipid clinic with LDL of 6. Okay, so we said this is unusually to have secondary dyslipidemia, but we will screen her for secondary dyslipidemia. So when we did the secondary workup, including lipid profile, including thyroid function test, hemoglobin A1C, liver and kidney disease, we found that she is really frank hypothyroid with TSH of 100. So we started the treatment, and I was really happy to counsel the parent about this is secondary dyslipidemia, and LDL will improve with treatment. So after follow-up visit of 1 month, her TSH normalized, but her LDL is still hanging at 5. So I said, oh, okay, 5 is really quite very high. Let's do genetic testing. And she ended up heterozygous FH, genetically proven. So she has 2-in-1. So we continue treating her thyroid function, and we start her statin, and luckily, alhamdulillah, her lipid profile improved. But we discovered 2 of her siblings with FH. So this is what we're alluding to is cascade screening. So evidence is there. We have tons of evidence that pediatric pathology, the atherosclerosis starts in pediatric age group. So unless we start really picking up this patient early, we will be really lagging behind and will not be following any guidelines, and all our patients will be in cardiac surgery for early intervention. This is again recent study published in 2022 about childhood cardiovascular risk factor and adult cardiovascular event, which really indicate and link that early risk factor starts from childhood. And unless we really start aggressively and in early life, we will not be able to achieve the target. And this is again published recently, and probably all of us aware about this frequency of FH in Europe. So when I ask our resident and fellow which is the most common inherited disease, they will say sickle cell disease. They will say Duchenne muscular dystrophy. They will say cystic fibrosis. But when we show them this graph, they will be really shocked that FH is by far the most common single gene defect affecting our population. This done in Europe, okay? So what about our data? Where are we in this graph? Okay, so this is a good question. So I just put the finding from Gulf Registry, and you can see the graph. Look at this is in Europe, and this is where are we? So we are off chart. We are off chart. So this is quite very prevalent disease, and this is I put it from the data extrapolated from Gulf Registry, which estimate FH prevalence 1 per 112. So awareness, we need really to increase awareness about FH among our health care sector. We did a study about measuring the prevalence and factors associated with dyslipidemia among adolescents in Saudi Arabia. So this is published recently. So please read this paper. It's very important and cited in your publication. Not to improve the impact factor, no, but it is really relevant to our patient. So this was a multi-stage certified sampling technique. We visited school children in different areas in Saudi Arabia. We have a sample from 12,000 child, but we did a sample like lipid profile for more than 5,000 child. So this study aimed to determine the prevalence of dyslipidemia and its correlate among adolescents in Saudi Arabia. Data from more than 5,000 adolescents between 10 and 19 years in all 13 regions Saudi Arabia were obtained from the GLUNA study, which is National Cross-Sectional Multi-Stage Stratified Sampling Technique. So the overall classification based on this category, either acceptable, borderline, or high risk, identify like 7%. They have high risk with a very high level of LDL, and 17%, okay, they have borderline high LDL level. And this is the graph showing the overall prevalence between dyslipidemia and among male and female, which account around 33%. So this is really quite high. And this is very relevant to our context, because when you speak about population level and the Ministry of Health covering all these sectors, we have a lot of work to do. Interesting, when you look to the regions from Saudi Arabia, you can have variable disease prevalence, maybe the highest in Najran, 44%, and the lowest is in Abha with 14 or 15%. But the range around 20%. So this is the spectrum, again, from different regions in Saudi Arabia. And I think this study can be a wake-up call to do more universal screening, at least in Saudi Arabia, with this finding. So evidence does exist that early intervention, starting from childhood, improves the outcome. Okay, and this is the cumulative event-free survival, which showed really significant improvement in children compared to adults. Because this is a little bit quite old study, but this again demonstrates that early intervention is very important to improve the outcome. And this is the difference, because I'm talking about different management of dyslipidemia, different disease, treatment modality. And thank you to previous speakers who shed the light about this. And I will not really go into detail. But among pediatricians, and this is common, pediatrician, general practitioner, they are afraid, okay, and reluctant to use a statin. And I think this is a good opportunity to show this study, which showed safety of statin in children, which is 20-year follow-up of statin in children with familial hypercholesterolemia. As you can see, very obvious from this study that children treated with FH have better outcome and they have better survival. Not only that, but they have lower LDL compared to baseline, and they have, if we look again here to the unaffected siblings, there's a trend, which is natural trend to have increased LDL with age. So statin is safe and effective to be used in children starting from young age. And it is very important to have this in mind, especially when we talk about high risk, high disease prevalence, high comorbid conditions, okay, and cheap drug. So the pharmacy department will not be upset from us. So what is available? What statin we can use in children? So it depends in your supplier, but in general, we use atorvastatin and rosuvastatin, and some use simvastatin, but in general, they are the approved. We have approved statin starting from the age 8 years and even lower. This is not the case when we talk about homozygous familial hypercholesterolemia. In homozygous familial hypercholesterolemia, we start really early. We start at the age of 4 years, 3 years, with very high intensity statin. We can use, for me, I use rosuvastatin because it's really high potency statin, and they go for dose escalation quickly and adding and building up the intervention. Quickly adding ezetimibe, then adding another treatment. Recently published European Atherosclerosis Society consistent treatment for homozygous familial hypercholesterolemia. What I really like about this is this box, okay? So this box highlighting treatment pathway for homozygous familial hypercholesterolemia in children adopted from this publication. So start with initial lifestyle modification, and we learn from Prof. Awan talk that lifestyle is not really going to help a lot in patients with homozygous FH because they are really healthy and they have normal BMI, and they are children, they are non-smoker. As it may be, okay, immediately start statin, then add ezetimibe, then go for more treatment. If LDL more than 8, consider lipoprotein apheresis, and I have a word about lipoprotein apheresis. And if LDL is continue to be high, consider novel therapy, and if not available, consider liver transplantation. So from this box, in our Saudi context, I can highlight 4 important messages, okay? And I think this is very relevant. And this is and I will tell you one by one. So this is the diagram. Initially, basically, rule out secondary causes, then rule out underlying genetic condition that can mimic or overlap between FH, like cytosterlemia and others. Then do genetic testing for FH. So at diagnosis, this is again homozygous FH. Start with statin combination with ezetimibe. Then, if not improved, not achieve target, add PCSK9 inhibitor. If not, then move to other treatment like lipoprotein apheresis, or consider, if you don't have the ability, use the other medication like lomitabide. Target is very challenging, very difficult to achieve, which is less than 3 millimole per liter in pediatric. So LDL apheresis, it is underutilized in our country, unfortunately, which can be used because we have time window between less than 5 years. There is no evidence for use any of other lipid-lowering therapy. However, apheresis can be used. It is available in some centers, but really it's underutilized when we look to the Saudi Arabia map. But if we look to the hemodialysis, okay, for kidney transplantation, for kidney failure, it can be adopted because the technique more or less the same, and the issue with vascular access. So really, I wish we have this facility across kingdom. And this is in our center. We use LDL apheresis for certain patient, and basically it will remove LDL particle. The drawback is the accumulation of LDL after like 10 days or so. So we have to have frequent LDL apheresis. Liver transplantation is an option, but it can be used for a small subset of patients. The benefit of liver transplantation is not without complication. And we published this paper about liver transplantation is liver transplantation curative in homozygous familial hypercholesterolemia, review of 9 global cases. Again, this is very relevant paper if you talk about liver transplantation in our context. So we can see really a very small portion achieve target with significant mortality. So again, liver transplantation is very high-risk procedure with long-term use or need for immune suppressive therapy, lack of organ, and with the emerging novel therapy, I think we are moving away from this option. I am very happy, صراحة, and I'm glad to show you data generated from Saudi Arabia. So this is, again, landmark study in the field of pediatric lipidology practice, which is top-line result from the ABH19 study, phase 3 pediatric trial for lomitabide in homozygous familial hypercholesterolemia. So Saudi Arabia is really well represented in this study. King Faisal Specialized Hospital and National Guard Hospital are contributed to this paper, to this study. And, but I have to disclose that still not yet published, okay? So just I will show you some preliminary data, which is very impressive. So this is a phase 3 study, single-arm, open-label, international multi-center study to evaluate the efficacy and safety of lomitabide in pediatric patients with homozygous FH. During the 6-week run-in period, after stabilization of patient at their maximum tolerable lipid-lowering therapy, treatment with lomitabide was started. Dosing of lomitabide was initiated and recommended starting dose and escalated to the maximum dose. During the 24-week efficacy phase, patients were required to remain on their stable lipid-lowering therapy, including LDL apheresis and others. 43 patients enrolled in 24-week efficacy phase. 20 patients were between 5 and 10 years, and 23 patients between 11 years and 17 years. 88% had genetic diagnosis, genetic confirmed diagnosis of homozygous FH. The mean LDL at baseline was 436. Okay, so there was really significant improvement in the primary endpoint with significant statistically and meaningful significant reduction in the LDL across different age group, and also if we look to the non-HDL and total cholesterol and VLDL, there were also significant improvement. So please stay tuned until we have the official publication, and this will be presented inshallah soon. Safety was consistent with the known profile. Mainly the GI upset was the main issue. 41 patients completed 24-week efficacy phase, 2 patients withdrew due to adverse event, and 5 patients had serious event, 1 considered to be related to lumitabide. The way to treat FH is really promising. We have novel therapies on the market and novel therapy on the way, including gene therapy. But I would like to conclude with these 2 important slides, like lowering LDL in homozygous FH depends how much you are aggressive, even if you are dealing with children. Using more than one agent, it will help to lower the LDL level. The treatment depends either you are using LDL receptor dependent pathway or LDL receptor independent pathway. Needs commitment from both the healthcare provider and the patient. The more agents you used, the lower LDL level you can achieve. We have really promising therapy, and including lumitabide, which is recently we finished a clinical trial on this, and we observed again underutilization of LDL apheresis in our practice. With this, I conclude, and thank you very much.